they consider the second through fifth digit. All right. I know the book says we just, like we're doing the second digit here. You want to center on. Remember, you have the proximal interphalangeal joint and the distal interphalangeal joint. So the book says we center at the second, or at the, the proximal interphalangeal joint, the closest one to the hand. Okay. So it's called the PIP, proximal interphalangeal joint. All right. So again, you want to just center on that, and on doing just the finger, you want to make sure that you include down through the metacarpal. Because a lot of times when people hurt their finger, it's because they jammed it, right? Any of you play softball or volleyball or something and jam a finger, right? But what happens is that energy will transfer. You may have, you may notice the pain more in your finger, but the energy can transfer down into your metacarpals, all right? In fact, what happens when we get to the wrist, you'll find that the big bone here in the wrist called the scaphoid, a lot of times when you jam your finger, you wind up breaking that bone because the energy transfers down your thumb through your metacarpal and into that bone, which is just kind of nestled into the base of that metacarpal, okay? So that's why we want to include the phalange and the metacarpal, okay? Depends on what your clinic site is. Some clinic sites want you to include the adjacent finger. But for our purposes, we just want to make sure that we include the finger with adequate collimation. And don't worry so much about getting your BBs in there, but do make sure you get your R or L, especially with these big honking markers. This is where the smaller markers, you have the smaller ones? Mm-hmm. Yeah, that's where these are an advantage. Because look at the size difference. Actually, that R is bigger. It's just so just the casing. Okay, so again, work it in there. But remember, the congruence between the light field and the exposure field can be off by up to how much? 2% of the distance, right? So 40 inches, that's 0.8 of an inch, almost a full inch. So you got to be careful putting your marker like this because you may have so much of a cutoff you can't tell whether it's a right or a left, and that would definitely count against you. Okay? So we have, this is our PA finger, right? Now, when doing just the finger obliques, whichever finger it is, you just turn the hand that degree of obliquity with the finger straight. And there is your oblique. If it's the middle finger, if you can, you separate and you turn it up. If you can, hold it out straight because we don't want it tilted down. Remember, when we tilt it down, we lose that joint space. So the fingers need to be as parallel as possible to the IR, right? And so again, if it's that fourth finger, the ring finger, again, with these, if it's other than the finger, you can have them flex those other fingers in and just rotate it. And again, trying to keep it as parallel as possible to the IR. And again, Mark, I know 2 facilities only allow 1 exposure per IR. So if you want to practice this way, that's fine. I know at Crestview I do all 3 views on 1 IR. In hand I do PA and oblique on 1 and lateral separate. But to keep it simple, just do 1 view per until you get a little extra experience, a little confidence. Then if you are a place where they allow multiple exposures on a cassette, then you can do multiple exposures on 1 cassette. Okay? And now for the lateral, again, if we're doing the second finger, now just have them point. Just pull that finger out. And if you need to, by using a sponge, with the other hand, you can have them just kind of pull the sponge into their finger, pushing those fingers back. Okay, but doing it this way, what do we have with that first finger?
Is it tilting down?
Well, no, that, but we have a lot of OID. So if we're doing the first finger, we want that lateral done by rotating the hand in, and then going to the hand. And remember, your collimators will tilt, so just keep it simple. All right. Again, trying to keep it toward the center. All right. And so that'd be the lateral. Now, if we were doing the third finger, then just tell them, stick that finger out.
Okay.
Okay. And so turn on the side and just stick that middle finger out, and then you may have to have them pull in with that, and again, just tilt the cassette a little bit. and then it's just attention to detail. Okay? All
For
right?
this, when you did her lateral this way, if that were the case with this finger, would you do the oblique?
No,
Oh, okay,
because you're just turning the, because you can do the finger oblique just by kind of rotating the hand.
okay.
Okay, but the lateral, you should do the lateral with, which rotation would this be?
Internal.
Internal or medial. So typically you just put the lateral on the medial aspect for the lateral hand. Remember, this is your medial aspect. So just stick the finger out like you're pointing, all right? And then again, if it was the ring finger, same thing, just have to stick that finger out, curl the other fingers in, and use a sponge, because people have a hard time sticking that ring finger out. So with that sponge, it's a lot easier to use that sponge to go ahead and push the fingers down like this. Now the pinky is easy, just tell them to curl all the rest of the fingers in, and that's usually pretty easy, okay? And so there's your lateral fingers, all right? So we've got the PA, obliques, and the lateral fingers, all right? Now, the thumb, the first digit, put your hand out flat, just like a PA hand, all right? Now, on the PA hand, the thumb is in the oblique position. When you put your hand out flat, the hand is in the PA position. The hand is in the PA position, but the thumb is oblique, right? And from here, I just tell them to scrunch their fingers up. And as they do, the thumb rolls into a lateral position. Okay? So I just turn that to her hand. Keep my borders parallel. Except here, you want to center at the carpal metacarpal, where the joint is by the base of the thumb. Because there's only one interphalangeal joint, because there's only two phalanxes, the proximal and distal. There's no medial. Okay? Right. So just go ahead and center here, which is the carpal metacarpal, or metacarpal carpal joint. Carpal metacarpal joint, rather. No, metacarpal carpal joint. No, metacarpal phalangeal, MCP. I'm trying to go fast, but all right. The metacarpal phalangeal joint. Okay? And so that is the oblique thumb. All right? Now, when doing the AP thumb, then I like to turn them a little bit so that their arm is out like this. Because with your arm out like this, try rotating your arm in. All right? It's a little awkward, but if you turn your arm out, now you can rotate your arm a lot further with no restrictions. See? Arm out straight, that's about as far as I can go comfortably. But I turn my arm out this way, and I can rotate my arm completely palm up. Okay? So just stick the arm. Okay, now again, this is where the little attention to details. You turn the cassette to match the long axis of the thumb. You turn this. And try to get it to the center. Say again? Yeah, you rotate the arm inward to the thumb is AP.
Can you just stick it there?
In the center of the cassette? Well, yeah, you rotate your arm out. Oh, it's so easy to do this. Okay?
It looks uncomfortable, but it's not really.
No, it's not. Okay, now if they've got some flexibility, you just rotate the arm in, and wherever the hand is, you take the cassette to them. And again, with the overhead tubes, it'll be a lot more convenient than this thing, which is not as convenient. There you go. But even that, all it takes is just a little practice. You got your hand in for the AP. Okay, so you want to make sure it's AP, make your final adjustment just before you step back. And again, you're trying to keep your collimation borders parallel to the IR, and adequate but not excessive collimation. Okay, either too little or too much, because you don't want to be doing a thumb and having a cone fill like that. Okay, because what is besides repeats, what is the best way to minimize radiation exposure to the patient? Proper collimation. Okay? So we've done the fingers, we've done the hand and thumb. Now all we need is the wrist. Okay?